Hello and welcome, and thank you for joining us for the 6th Annual Global Summit on Kidney Innovations, Vox Populi. The time is now to prevent and cure kidney diseases. This summit is hosted by the American Association of Kidney Patients in partnership with our allies from George Washington University School of Medicine and Health Sciences. My name is Dr. Barry Smith. I'm an AAKP board member from New York in the United States. I have a long history in kidney disease, was the head of the Rogerson Institute for more than a dozen years, and am committed to seeing to it that kidney disease is eliminated and that people with kidney disease are better taken care of. Being part of AAKP for about 20 years, I have learned to hear a lot of different voices about what kidney disease is and how it robs people of some of the important parts of life that are enjoyable. And we don't need that to happen. And much of kidney disease can be eliminated. And so we need to work on that. This year's Global Summit theme, Vox Populi, was purposely and strategically chosen by AAKP for its historical meaning, voice of the people. I am one of the people who have chosen to raise my voice in support of greater care choice and innovation in kidney care, and I am one of the voices demanding a change in status quo kidney medicine. Now, as you may know, over 850 million individuals across the world have kidney disease. This number is increasing at an estimated rate of 5 to 7% annually. Every year, we lose thousands of innocent lives to preventable kidney issues and the lack of timely access to treatment. AAKP believes kidney disease is both a workforce and a healthcare issue. This disease takes a devastating toll on human lives and livelihoods. Most people understand that kidney disease left undetected and untreated can lead to premature death. But many are not aware that it impacts a person's dignity and ability to provide for themselves and their families. Kidney disease and outdated treatments can lead to unemployment, underemployment, disability, and dependency. In 2019, AAKP declared the next 10 years the decade of the kidney. The time is now for kidney patient consumers, healthcare professionals, researchers, industry, and all people of goodwill to unite our voices and demand change. We are optimistic that we can and will save more lives, but to do this, we must demand new screening guidelines and diagnosis, new biologics, and new devices. Together, we can manage and solve this growing public health care crisis. The time is now for elected and appointed leaders worldwide to listen to patient voices. Governments must remove the regulatory and payment barriers they create that delay innovation and prevent timely care access. If government fails to act, we must raise our voices and demand an end to negative government determinants of health. Make no mistake, every nation is impacted by kidney disease and millions of people are at risk. The optimistic news is that every person watching this program today can help those impacted by kidney disease and make an impact within their own nation. Through AAKP Global, AAKP is educating patients, care partners, healthcare professionals, and policy leaders across the world on unmet patient needs. Our annual Global Summit on Kidney Disease Innovations has helped us put a human face on what is now the 10th leading cause of death based on data from the World Health Organization. We have connected people across the globe in a common purpose larger than any one purpose or nation, or one person or nation. Together, we have increased hope and optimism. So thank you for joining us. Your voice is the voice of the people, and you can count on AAKP to keep amplifying it throughout the world to create change. With that, I am honored to serve as the moderator for our session entitled Impacting Community Health with Global Implications. Now I'd like to welcome a team I know quite well here in the state of New York that will speak to community health issues and approaches to them right here in the U.S. We're honored to have with us today the physicians from One Brooklyn Health, Mount Sinai, and Assembly Member Nikki to talk about these questions. So I'm going to ask the first one to Dr. Kostelantez. What tactics do you use to help build or rebuild trust and build sustainable relationships among healthcare providers and the communities that are often overlooked or historically underserved? What do you have to say?
Thank you, Dr. Smith. We're honored and privileged to be in this conversation with this group of wonderful people, experts who have been doing this work for such a long time. I would start with saying the first priority has to be being trustworthy. So that means an increased external transparency to patients in patient language that is accessible around where are we as a health system? Where are we regarding a lot of the challenges structural that we may have in terms of being able to provide access to care to our patients in an equitable manner? Are we transparent around the challenges that we have? Are we transparent around the strengths that we have, as well as the opportunities to be able to improve the health system in a way that really centers community voice, community priorities? So these tactics can include things like creating community advisory boards and patient family groups, not that are just performative and present within an institution, but more importantly, are sitting at the table in shared leadership, shared power with our decision makers. That means all the way up to the level of the board. That means sitting on our quality committees and being able to bring their expertise. In medicine, a lot of times we love to rely on what we call an evidence-based solution. The challenge we often see in the communities we are working in is that the evidence was never generated in the reality of our patient communities, of our hospital systems. So that requires us to equally center the lived experience of our patients and the realities of our institutions. That also means being able to have the training and the ability to name the structural problems. We have to be able to name racism and be able to describe how structurally racism today is still harming the communities, the hospitals that we are working in. Whether it is in examples like the inclusion of the race variable within race-based EGFR measurement and all of the advocacy work over several years that has been going on in New York City around eliminating that variable and providing more equitable access to diagnosis, transplant care based on the more appropriate, accurate measurement of the EGFR. Whether that is around naming racism and desegregating healthcare, where we know that today we still have a segregated system. It is segregated across hospitals in terms of which patients are able to seek care at which hospitals. That is related to also how are hospitals paid. When we are primarily in our community serving patients who are almost exclusively Medicaid, some Medicare, and the reimbursement rates are 6 to 7 times less for the same work than if this was a private insurer, then we have to be able to name those structural issues with our community transparently and advocate to what is it going to take to be able to have the structural investment needed to care for our population. And then certainly, last but not least, in this shared power with community advisory boards, patient family groups, also really taking the opportunity to engage and develop a workforce of community health workers and peer navigators, ambassadors, folks who are living with kidney disease in our community, both to support patients, support the navigation that needs to happen, as well as being able to understand the challenges that we have and the partnerships that we need with our community and community-based organizations.
Thanks, great. And following up on that, I'd like to ask Dr. Spitalewitz, who's the chief of nephrology at One Brooklyn Health and who's had a long history there, 40-some years, I believe. Ask him the second question, which I think follows very well on what you've said, Dr. Kostelantez. AAKP believes all patients, regardless of their socioeconomic status or place in society, have the ability to make decisions about their own health if they are provided with accurate information. Can you tell us about the information that should be provided to people in this regard, understandable information without medical jargon and so forth? How do you see that? Because that's something we need to do much better.
Yes, sir. I'm happy to participate. There are two ways of disseminating information that is understandable to patients, both in a formal way and informal. In a formal way, we've now partnered with other institutions. There is one program that's called PEAK, which is Prevention and Education in Advanced Kidney Disease. This is a program that is specifically designed to provide information in an understandable way to patients that have been identified to have advanced kidney disease, usually stage 4, if not further along. And as part of that program, there are ambassadors that participate in meetings. These ambassadors are patients that have already navigated the system, successfully or otherwise, and are in a position to discuss and explain in layman's terms to the patients that now are approaching end-stage renal disease and discuss with them the options of renal replacement therapy, which unfortunately is likely to occur in the future in these patients. So that would include information regarding in-center hemodialysis, peritoneal dialysis, home hemodialysis, and of course transplant. And having those patients that have gone to each of these modalities and discuss it with them what their experience has been is really it's an amazing interplay that the patients have, more so than a physician can participate in. There's also a protocol now that we're involved with that also involves education of the patients, including palliative care options where patients are given the opportunity to say, well, I don't want anything. I don't want dialysis. I don't want transplant. I don't want to be bothered. I just want to live out my life and have conservative treatment. So that's another formal way of getting information out there. And recently, I'm happy to say that we've partnered with a very active institution in New York City for transplant satellite center, where we have specific teams, including the social worker, and again, patients that are already transplanted that meet with the patients and help them undergo the workup that's necessary to go to transplant. And this is an opportunity that has not been available to many of our patients, unfortunately. So we're expanding in that direction as well. In terms of informal ways, we have a CKD clinic that is run by my colleague, the younger Dr. Beatty, that is not here today, where we are now trying to understand why there are no shows that are sometimes as high as 30% or more, and are attempting both in, informally, certainly by discussing the information with the patients regarding what their blood pressure is, what it means, what proteinuria means, and give them a card at the end of each clinic where they themselves fill out what they're given what their protein excretion is, what their blood pressure is, what their hemoglobin A1C is, for instance, and they then understand and have a trend going forward and say, well, I'm doing well or I'm not doing well enough, and are prompted to come back and understand, well, I didn't do well this time. Maybe it's because I wasn't able to come in. And I myself also, since COVID, have become to understand that telemedicine is a valuable tool. Just yesterday, I was telling Sophia before we got on that patient that was unable to come here because of the restrictions in travel. We had a telemedicine call, and all that I discovered during that time was that she was unable to, or she misunderstood my last instructions to her regarding medication. So telemedicine and having the availability of a physician, even by cell phone, which I do give to select patients, though I think we're not going to abuse the privilege, to discuss more in detail in a way that is less formal and little more in a way of that they can understand what the disease is and what to expect. We've also reached out to the community and have been invited. We've had health fairs where lay people have been at our post taking blood pressure, explaining what the blood pressures are, and we are now going to be going to local churches, and we've been invited to go to a local high school to discuss hypertension and kidney disease directly with the patients there. And probably it will be a nurse practitioner or a social worker with a renal fellow or perhaps an attending to give information to those patients who are in sorely need of that information. I think that about covers it. Is there anything you'd like to add, Sophia, to that?
Yeah, I completely agree. Our responsibility as an institution to ensure that all of our communication is culturally and linguistically appropriate, that we have the interpreter and translation services, that we are ensuring that they are called every single time, and that we are also hiring folks from the community, as the main as a main employer in Central Brooklyn. It is really critical that our workforce, from the front line through to executive leadership, is reflective of the community that we are serving. And that better allows us to understand how to serve our patients.
Let's follow up on that, Dr. Kostelantez, with New York State Assembly member Nikki Lucas, because I think we as medical people have not necessarily worked very well with the people who set policy and who vote and approve legislation and so forth. So, Nikki, from your side, what can be done to improve the kind of collaborative spirit that needs to be developed? Because people look to you, and that's why they elected you, to provide leadership for them, and we need to somehow put the community, the medical profession, and the political leadership together, or at least I think we do. So I'll let you take it from there.
Thanks, Dr. Barry. And I just want to say that I do echo much of what the prior speakers said. They were very spot on. The onus is not just on the medical professionals, the onus is on the leadership with the elected officials. When we are making policies, sometimes the people that it's impacting are not considered or not spoken to. So, number one, that's something that has to happen on a consistent basis. I'm excited in this particular district. We have all of the electeds for the first time in 20 years actually on the same page, communicating with each other on all levels of government, which is extremely important. But one of the things that I'm most excited of is the partnership as well with Rise Up. Um, from the beginning, you have to have someone who is genuine about the investment in the community. That's number one. And Dr. Barry, I don't want to toot your horn too much, but the reality of it all is that you have been a trusted partner. I met you during the what is that, the kidney, um,
Opening
the dialysis center. And it was amazing to me that you indicated that you don't want people to come in here, even though that was the business of which you were partly in. But you were more concerned about preventive care. So that to me told me that you were genuine about the overall health of this community. So that's one. So I saw you as being a potential partner, and we eventually became that. In developing relationships, moving around the community, really kind of creating a partnership where people could see us as credible voices. And that's something that Sophia spoke to earlier, just having trusted partners. You can't walk into a facility and no one trusts you, because then you're just going to be giving out pamphlets and nobody's going to follow up. We also have health fairs where folks are coming through and they're passing out pamphlets and no one follows up. So what we decided to do in partnership, one of the things is to make sure that when we are doing events, whether it's a book bag giveaway, whether it's a concert, whether we're talking about Christmas or Thanksgiving, we need to make sure that we're integrating resources in those events, not just passing out pamphlets, but we want a truck out there to make sure that we're giving blood work, taking blood work, taking urine samples, making sure that people are getting their prostates checked, mammograms. We need to have these things on site in real time. But how does that happen? You need funding, right? So we need to have more conversations about how we invest in that on the elected level, not just in terms of policy, but policy has to be supported with funding. You can't just do these things without building capacity. And in order to build capacity, you need money to do it. You need to pay doctors, right? You need to make sure that in these hospital settings, that you're also having an appropriate nurse, hospitalist, or doctor-patient ratio. That you're able to handle. For one, my dad's in a hospital right now. I became more and more educated on some of his issues, especially in nephrology, because I asked 1,000 questions. But I wouldn't have known any of this because it's not really out there. So another part of that is bringing the hospitals out into the community before we get there. Right? Let's not wait until something happens. Let's be more proactive as opposed to reactive. So those are additional partnerships that can be formed to say, hey, look, let's do some consistent community information. So let's educate people on what it's going to look like if they walk into this hospital. What can I walk them through in terms of the information that they need to know? I didn't even know what a hospitalist was until 2 weeks ago. Right? This is something that happened, that you established in a hospital setting. I don't know how long ago this happened, but anytime there's updates, the community should be updated as well. And again, not just when they arrive in the hospital. So credible validators, trusted faces, making sure that we are including all of those who are impacted, including the medical professionals, the members of the community. And the process in which I'm laying out is not just for me as a politician, it's for every setting that's in this community. If I walk into the hospital, this process should be the same. If you come to Albany, the process is the same. And we want to make sure that we are partnering, considering, and educating. And in addition to that, there's some policy issues, right? We want to talk about paying Medicare and Medicaid benefits. It should be equitable, right? We want to talk about patient ratio. We want to talk about transportation. Many people are coming to these hospitals late, missing their appointments because they cannot get their accessoride. Right? How many people are thinking about that? But that's a real thing that's happening in our communities more often than other communities. But we have to have those conversations, making sure that any of the healthcare benefits, there's many of our healthcare providers that don't even have housing. They are homeless. They are bouncing from person to person. They don't have access to getting to work. So we can't just talk about this from one point of view. We have to look at it from a more global perspective, a holistic perspective, and talk about these things on a consistent basis and be able to support. I can't be out there advocating for something that I know is happening in my community because I'm here and I look behind me and no one's there. I want partners. I want to partner with my medical professionals. I want to see my members of the community sitting on these boards. I want to say that when you are making sure that you're economically empowering our community, that you're doing proper job training, that you're giving prevailing wages, right? That you're actually offering it to people within the community in which they come from, not just saying, hey, let's just hire Brooklyn just to go along with the quota. Let's hire the people that actually live here. Let's have those conversations with the unions to make sure that they're being equitable in their hiring, because we have some concerns about that. We want to build generational wealth in every community, not just in some. And so just going on to those collaborations, those are some of the things that we can do, not only person-to-person collaborations, making sure that those things are accessible in events. There's nothing that we should be doing that doesn't add value to someone's life, including our own.
Great point. And I think health runs through everything that we do. Our society simply doesn't work if we don't have health. So I think what you're saying makes very good sense. And to be even a little bit more specific, Dr. Motegi, you're doing some things to involve the community. Tell us more about those and what you're doing.
Sure. I want to just say again, it's an honor to be here with all these other folks who've been, deeply committed to community engaged action and policy change. I'm a general nephrologist. I primarily take care of veterans now here in the Bronx in New York. And prior to being here, I was in North Carolina for 20 years, so got to see how policies in different places essentially impact the care of people with kidney disease. And one of the most amazing opportunities I've had is to work with our national advocacy organizations to ensure that patient voices and experiences and community voices and experiences are integrated into the larger scale policy changes that we see. So I'll just provide an example. As a nephrologist, the concept that was already mentioned resonates so deeply with me that what I don't want is for people to come and see me in a dialysis unit, having never met them, having never been able to intervene on actually preventing their kidney disease. But once I do start to take care of folks with dialysis, I know with dialysis needs, I know that transportation barriers, housing barriers, the inability to access affordable, healthy food, the inability to understand the materials that we're giving them. This is complex information, for instance, around transplantation. All of those structural barriers get in the way of ensuring a person can live the best, healthiest life that they can. We've known this for now quite some time, and yet we haven't really had a way to account for some of these things that we know people on dialysis are experiencing. For instance, homelessness, as was already mentioned. And due to patient and community advocacy through a number of our national organizations, AAKP, the National Kidney Foundation, and others, the Center for Medicaid and Medicare actually changed forms that all of us are required to complete for people undergoing dialysis. The 2728 forms in their new iteration now require us to ask about transportation, housing, the ability to afford medications, the ability to understand information. And a key issue that has actually been sort of missed for decades now, right? Which is, did you even get information or education about transplantation, doing dialysis at home? We know there have been stark racial, ethnic, and socioeconomic disparities in who can get a kidney transplant in the United States, now described for almost 20 years. And it takes policy solutions sometimes to shift the needle on this. And I think the fact that CMS has recognized that all of these structural factors are important by requiring us to fill out these forms and hopefully investing in actually taking action on those forms is one huge win. The second win, I think this is one that has been most deeply moving and completely related to community voices and a tremendous amount of advocacy, is the fact that although Black Americans were uniquely impacted and harmed by race-based kidney function estimations, due to community action and advocacy, in an unprecedented decision, our United Network for Organ Sharing, our transplant organization that oversees this in the United States, developed a policy that actually restores wait time to people who are harmed by the use of the prior Black race coefficient. And I would just encourage everyone to, if you don't know about this policy, to go to the UNOS website and just take note of the fact that already since this policy was introduced in January, a median of 1.7 years of wait time has been restored to Black individuals. This is just a really important message to get out there. If you have had a kidney function estimated using the prior equations, and that hit the eligibility requirement for transplant of having an EGFR less than 20, you may be eligible for this. So you should be talking to your clinicians about this. And again, this is a wonderful example of how people impacted by inequitable policies and community members came together to actually drive a policy change that has impacted, again, thousands of Americans to date. So community voices should be at the core and at the center of policy change and policy advocacy. And it is possible through action and sort of sustained advocacy to see some of these wins, even if they take time. And it is our job, I think, as clinicians to partner with communities to bring about these changes. There is nothing more powerful than me sharing a story or empowering a patient of mine to share their story about the structural barriers they have faced in driving these changes. And I will say that whenever I have an opportunity to engage patients or community partners in that advocacy process, I try to do that. But more importantly, I take it very seriously that every story that I heard, that I hear in the care that I deliver, becomes an impetus for my own advocacy whenever I have the opportunity to do that. It's a privilege to do that.
Great. Well, that makes the a huge point. The community voice matters, but it has to be together with the physicians, the clinical people, with the political people. All of us have to get together to make these changes work effectively. And, I think one of the issues that came up earlier, and Dr. Spitalewitz mentioned it, but Dr. Kostelantez, you might add some to it. Technology is an important part of what we can get the word out to people in different ways now. Give us some perspective on what you see in that regard, because things are different. The community voice can be amplified in a very different way than it was before, and the health professional voice as well. So please.
Absolutely. So I think technology in terms of our capacity to care for patients is critical, especially following COVID, our learning around how are we able to deliver care, being able to leverage technology, and sometimes decrease the barriers from the adverse social determinants of health. So if we have challenges around access because of transportation or distance, our ability to leverage telemedicine and provide better care, more frequent follow-up care, being able to leverage applications such as MyChart that we have in our institution that allow us to make sure that all of our patients can have the information at their fingertips from every single detail of the note that we wrote in the medical chart. And that means certainly we have to ensure that that technology is equitably available, that there is access to high quality internet in all of our communities equitably, that there is access to smartphones and access to computers and web services to all of our community, whether that means that is starting through schools, through libraries, so that all community members can have what they need to be able to have the benefit of using technology. That said, I think we do have to be careful to not look to technology to be the solution to all of our problems. There is nothing stronger than the collective power of organizing of communities. So I'll bring forth a really important example for New York City has been through the New York City Department of Health-led coalition to end racism in clinical algorithms. So we have been able to more clearly name and show over the last 5 years, not just related to EGFR renal function measurement, but a number of algorithms that we use in medicine, some that are very clear, we call them hidden in plain sight. Was a very important academic paper that was published that began to show the algorithms where we're using race. What is a social political variable doing in an algorithm to decide your risk of C-section, your risk of kidney function decline, your risk of pulmonary function tests, and how what is the function of your lungs. None of that has to do with sociopolitics on a true functional level. We may have measured at some point the lived impact and the effect of racism, not race, within our systems. So when we bring collective groups together, as New York City Department of Health has through this coalition, we're able to identify what are these structural factors that are harmful, and then understand our collective ability through technology as well to eliminate them and to right those wrongs. So how we are able to bring over 10 hospitals together and say, let's all get rid of these practices in these algorithms. Let's all look at the impact through understanding our electronic health records and where are we able to get time back for our patients, as Dr. Danushka was speaking to earlier. So all of these elements are critical, married with technology, ensuring that technology is equitably available to our populations, and doing it again grounded in our community in a way that lifts up that voice, whether that is from the patient advisory groups, as we spoke about, the advocacy groups, including elements such as community-based participatory action research in the way that your hospital functions when you ask these questions. Go out to the community and ask them through a structured survey system that allows hiring of your local folks to ask those questions within their communities. Take that information and then bring it back to the hospital to help us inform what we need to be able to do differently. And then to the assembly person's messages, this has to be structured into our policy as well. We are fortunate in the state of New York to have the 1115 waiver, which is a Medicaid payment scheme that allows us now in the next several years to not only fund the direct clinical care, but ensure that we are asking those social care questions that are critical for our patients around transportation, their ability to have housing, food, all of those social determinants that Dr. Danushka spoke about, and then be able to fund our partners, the community-based organizations who are the ones that are doing the work of supporting our patients, getting the medically tailored meals, helping with the transportation, ensuring that we are not losing access to housing, or that the quality of housing, if it needs to be changed, that we have the funding and the support to be able to do that work in the community.
Terrific. Well, I think we've covered a lot of ground today. Obviously, there's much more to discuss. We need to start with young people to prevent them from having the chronic illnesses that end up with kidney disease. We need to deal with the people who have the kidney problems, which we've been talking about as well. And as a final word, Assembly Member Lucas, would you like to add a word about how we can all work together more effectively and go from there? Thanks.
Thank you, Dr. Barry. This is the first step, having these types of conversations. However, we need to have these conversations outside of this particular group, right? We have to make sure that these conversations are being had on a broader scale. Additionally, I just wanted to add, I'm probably not supposed to do this, but we spoke about a couple of things that I just kind of wanted to jump in a little bit on. Just having access to broadband and not knowing how to use it, that can be problematic, right? So we have folks that come into my office and we have to set up email addresses. I spoke to a couple of people in the hospital that my dad is in, the system in which they're using with MyChart. Some of them didn't know how to access it. So they also need to make sure that there's training with that. I'm fortunate to have a sister who happens to train on the Epic system. I have a sister who's a social worker, but that is not necessarily what's in everyone's family. So we have to make sure that people are able to access these things and are trained in the use of it, both community and medical professionals. Additionally, when we're talking about administering these surveys, the people that are putting these surveys together also have to look like the people that they're representing, because there are clear cultural differences that you're not going to understand when you're putting these questions together. And there's some questions that you need to ask that you may not know to ask. You're not being malicious, you just don't know it. But you have to include the people that are being impacted when you're putting these things together. And then lastly, there has to be some level of oversight. Right? We talked about transplants and organ donors. Our community is not trusting of that process. We're afraid to actually check off that we want to organ donate because we don't know if that's going to lead to an early death, right? In our organs being stolen. I want people to really understand in this space that these are the things that's happening in our communities, whether it's a myth or not. Things that have happened to us in the past really dictate how we think right now. And so when we talk about transplants, when we talk about organ donors, who's receiving it and who's donating it, right? Those are two different things. And so we have to get past those things as well within our communities. And that means that we have to change the faces behind these organizations. I have people that come in my office and it's only, they look one color, one background. It's not diverse. We need to make sure that these things are diverse. We need to make sure that there is a level of oversight, not just data collecting, but let's check what happens. Let's track the results. Let's look at what's going on in our communities. So I just wanted to add that. I wanted to say thank you. This is extremely important. But what I'd also like to add is that this should not be the last conversation that we're having about this. We should continue these discussions. This should not be a one-off. And I'd like to see it more expanded within the communities in which we're representing.
Thank you, Assembly Member Lucas. And now let's bring in Crystal Matthews for a few words.
Thank you, Dr. Smith. It's vitally important for the community to take an active role in their health. Community members should feel empowered to know that they're in the driver's seat of their own health. As a community member, don't be afraid to share and don't be afraid to ask questions. Know that an educated community is an empowered community.
What a wonderful presentation that was on impacting community health with global implications. We extend our gratitude to all of our speakers from across the world joining us.